Hello, this is Dr. Bhaumik. Uh, at this session, I'm going to discuss about management of diabetic ketoacidosis. And as you can see that I made management made easy because diabetic ketoacidosis lecture can be pretty elaborate and it can take more time. But my goal has been to compress the lecture in such a way that it will be very helpful for a pediatric house staff who is working in pediatric emergency room, pediatric ICU. And it will be also helpful to the pediatric nurse practitioner or in general to the pediatric resident, and that's how I have designed this talk. And I am a pediatric endocrinologist, by now you know, and I have to tell something up front. Each and every pediatric ICU they have their own protocol, and the clinical equipment and the judgment of PICU attending or the endocrine attending is always going to be uh, taken into consideration, and their equipment has to be respected because this is just a guideline. So there will be some variation. Your attending might do it a little bit differently, but really doesn't matter. And with that thought in mind, let's discuss what is my goal and objective at this session. I will discuss the basic pathophysiology of DKA, practical pointer as soon as the patient comes to the emergency room and its management at that time, ICU and PICU management, and how we monitor this patient and how we interpret their laboratory data. And obviously also risk factor, early recognition, and the treatment of the most devastating condition or complication that can occur during the treatment of diabetic ketoacidosis is cerebral edema. I found this diagram is simple, however it says everything that you really know. We know a pathology of diabetic ketoacidosis, type 1 diabetes I am talking about, is the basic fact is that they are insulin deficient. There is absolute deficiency, could be absolute or relative. But most of the time when they come with DKA, we should consider that it is a absolute insulin deficiency state. So what happened as a result of that? It has effect on carbohydrate, protein, and the fat metabolism. Let's look at this side and see what happened to carbohydrate metabolism. This is a very nutshell and very basic. As a result of insulin deficiency, there will be decreased glucose uptake inside the cell, and which will result in hyperglycemia, and hyperglycemia means there will be osmotic diuresis. Okay, let's stop there and go to the other side. What happened to the protein? There is, because of the insulin deficiency and because of the energy shortage, the protein will start breaking down. There will be protein catabolism, and that will increase the amino acid, and the amino acid increase the gluconeogenesis, that in fact increase more glucose in the blood, hyperglycemia. and obviously the nitrogen will be lost through the kidney. Okay. So let's go to the fat metabolism side. There will be a breakdown of the fat. This all happened because of the insulin deficiency and to provide energy to the body that we so badly need at that point. So there is increased lipolysis, and it breaks into main area with free fatty acid, which result in increased ketogenesis, ketonuria, ketonemia, and ketonuria. And that also result, ketonemia means acidosis. And here the glycerol part contribute to gluconeogenesis, and that's again add more to the hypoglycemia, making the picture even worse. And because of the osmotic diuresis, what we lose? Electrolyte, and fluid loss will result in severe dehydration. So with that fact, let's go and discuss the next step of our management. Right? The first thing when the patient present in the emergency room, either a known diabetic with DKA or a new onset diabetes, the first consideration is fluid resuscitation. The second consideration is the insulin, and then third is potassium administration, and I will discuss this thing as I go through and when to start insulin and give potassium. And the bicarbonate, which I just mentioned, is hardly ever used it, and there is controversy. Maybe very few scenarios where bicarbonate may be used, and additional measures that we do to make sure the patient is not going in wrong direction. So when the patient get into the emergency room, we all obtain the vital signs, and blood sugar or blood glucose should be checked at the bedside every hourly. We should quickly assess the state of dehydration, mental status, and the quick physical examination is also important. Laboratory wise, there are lots of lab that people will do, but mostly the lab chemistry or chemistry profile that will include your electrolyte, kidney function, liver function, and get a blood gas, and a pH that is obtained from the venous blood will be as good most of the time. So you don't have to spend a lot of time to get the arterial sample, since you are going to draw venous blood anyway. Just quickly check the pH from there, and there is a little correction formula which actually fits very nice with the arterial pH, and which we will discuss a little later. And so most of the time that the lab test is done in the emergency room, and immediately more or less we start giving a normal saline resuscitation, or what we call normal saline bolus, and which is about 20 ml per kg as soon as possible per hour, 20 ml per kg, and that should be infused as fast as possible. And then one might go to see the patient degree of acidosis. That could be done clinically as well as some classification definition, and these are just a definition, but just worth knowing, have some idea. When you call somebody the mild dehydration, usually had pH more than 7.25, and bicarb level of above 12, dehydration is just probably below 10%, and the patient is talking, there is no changes, talking coherent, and no changes of the intellectual or mental change function. The moderate is pH is 7.15. Again, I'm discussing the venous pH. Bicarb is 8 to 12. Dehydration is about 10%, and patient may be lethargic but responding appropriately to the verbal commands and also oriented. The third classification is the severe, where the pH is less than 7.15 and bicarb is less than 10, less than 8, with dehydration 10% or even more. It will be more than 10% dehydration, and the patient has altered mental state, disoriented, and even sometimes in coma, but incoherent. That's the most of the time they say they are very incoherent. Again, I like to say this is a guideline. It is not meant to replace the clinical judgment of your emergency room doctor or PICU doctor, just a guideline and the start point. So, do not give more bolus unless the patient is in shock or has state of dehydration and has affected the perfusion, and the patient may be hypotensive. In that case, everything is over. You got to give fluid bolus to get the patient good perfusion and also correct the dehydration. So that will be prior. So as I said that initially 20 cc per ml bolus, but that may have to be repeated depending upon the situation. Use normal saline. I prefer to use normal saline, but some people use ringer lactate because they are worried that that might saline has chloride, normal sodium chloride, might add more to the chloride and make the patient worse hyperchloremic metabolic acidosis. But I have not seen much difference ringer lactate or normal saline. Whatever your attending prefer will be fine. The standard teaching by American Diabetic Association as well as the Pediatric Diabetic Committee is that use saline about 150% maintenance, 1.5 maintenance, or 2500 ml meter per meter square per day after initial bolus. Now, again, this could be changes or has to be changes, but this is outline. We do not like to overhydrate the patient or keep too much fluid because most of the time in pediatric diabetes, DKA, we do worry about cerebral edema. So after a fluid bolus resuscitation, insulin drip may be started in emergency room, and especially if the delay is expected, and the fast acting insulin is used in the insulin drip. And some people used to go up the prime dose, but that is not necessary anymore. Just insulin infusion, the standard that has been practiced is 0.1 unit per kg per hour. Again, that may change later on, but initially this is a good start. And monitor blood glucose hourly. If you see that a bed is not available in PICU as yet, and the patient might stay in the emergency department longer than expected, then add potassium with the IV fluid, but they usually done after insulin drip. The two things that one need to be aware before starting is potassium is if the patient is voiding and if the potassium level is more than 5, then most of the people will hold the potassium in the IV fluid. And the amount of potassium that you use in IV fluid is about 40 milliequivalent, 30 to 40 milliequivalent per liter. And if the blood glucose has dropped to 300 or below, dextrose should be added with the fluid. It's a 5% dextrose with normal saline if the blood glucose has dropped to 300 or less. Monitor pH and electrolyte every 2 to 4 hours depending upon the severity of the condition the patient has presented, and watch for neurological deterioration. This is of utmost importance. The neurological examination should be done hourly and very seriously it should be taken. That neurological examination is very, very important. And when the patient is transferred to ICU or PPICU, one can continue with the normal saline, and as I said that if the sugar drop, you can start the dextrose. Now there is a little guideline, but this is not written in the stone. If the patient is less than 4 years of age, then 0.45 saline may be appropriate. Patient is between 4 to 9 years of age, 3/4 of a saline may be appropriate with 5% dextrose, and if the patient is more than 9 years of age, then 5% dextrose in normal saline will be adequate. I have seen some people try to subtract the initial fluid bolus that was given in ER when they calculate the fluid, but I don't think that is necessary because the polyuria is so virulent or so much that it will just wash out quickly. So you don't have to do that and keep things simple. And the saline that's going with the insulin drip is not also necessary to be subtract from the total fluid calculation. Some people do are very, very, very peculiar, but I personally feel that's not necessary. The standard teaching is that limit the fluid infusion to less than 4 liter per meter square per day is a good guideline. No need of giving any additional bolus for tachycardia only. Remember the patient has acidosis which will take a while to get corrected and itself will give you tachycardia. So that should not be reason to give another bolus. However, if the patient has got poor perfusion or hypotension, any reason to believe that the patient fluid replacement has not been adequate, clearly the extra fluid will be necessary. And I used to see that there always how you are going to make a 3/4 saline, just 50-50. Normal saline, half normal saline, that will be 3/4. So this is here in the board. They will ask that how much blood sugar you want your patient to drop hourly. Ideally is 50 to 100 milligram per hour. But I have seen in even the best situation, sometimes it falls more than that, and even with all possible precaution that you take. So, but this is the ideal, 50 to 100 milligram per hour. And as I mentioned before, change the IV fluid to dextrose with appropriate saline when the blood sugar is 300 or low. In first 24 hours, one should be happy if the blood sugar has been brought down to 200 to 300 ranges, and that should be very adequate, or even a little bit more will be adequate, but not hypoglycemic level. And if sometime we have seen that the blood sugar is dropping actually fast, even with the standard infusion, one can easily change to 10% dextrose or 11, 12%, whatever the situation calls for. And remember that if you are not giving adequate amount of saline, then your blood sugar may not come down the way you want, or it might fall too rapidly if you are not giving adequate amount of fluid or overhydrating. So one has to play a balancing game. Again, sodium deficit, which is there more than what you get in the initial blood test result, because in diabetic ketoacidosis there is a pseudo hyponatremia, which I will discuss a little bit in the later slides. So half of the sodium deficit should be corrected in first 12 hours. And I have seen the proposed fluid therapy and careful monitoring usually does that. If sodium is falling too rapidly, the sodium level in the IV fluid should be increased. Potassium depletion occurs in DKA, although the initial potassium level is high. That's because the intracellular potassium is now outside, because hydrogen ion has gone inside the cell as a buffering mechanism. So there is a significant potassium deficit, but serum potassium level in the beginning is high. Standard one would add 40 milliequivalent of KCl. In many PICU or institution, they have used half as a chloride and half as a phosphate, and that I will leave it to your attending. And obviously they will be hooked with EKG monitor for 24 to 36 hours depending upon the patient condition or improvement of patient condition. If the potassium falls less than 2.5, you may have to administer potassium chloride per kg, 1 millivector per kg over an hour, and one would probably like to hold the insulin drip until the potassium has come up a little bit, and it should be close to 3. Okay, and for hyperglycemia, if you see that don't give any bolus insulin, we should continue with the IV insulin infusion. Danger, or you are going to face problem with this management if you see this thing that I am going to discuss in this next slides. If there is no improvement of acidosis or worsening after 2 to 3 hours of the therapy, reassess and make sure their insulin drip is properly connected and the patient is getting insulin. You may also make sure your pharmacy has put the appropriate amount of insulin in the fluid. So there has to be a little bit of detective work before we increase the insulin dose significantly. The other thing is that if you see the serum sodium level is dropping as well as the glucose is falling rapidly, that's a bad sign. We do not want to drop sodium and the glucose rapidly, and that actually a big factor for cerebral edema. Do not ignore to monitor the patient and examine neurological examination, and headache, hypertension, bradycardia, unequal pupillary reflex, and seizure, these are omnibus signs of brain edema. However, headache could be very common with the DKA, but in the absence of all other things, you like to continue with your neurological examination. So what are the risk factors for cerebral edema? Cerebral edema is the one which contribute to the mortality and morbidity of DKA when we manage DKA. Younger age, usually less than 7 years, and new onset diabetes, they are a little bit more vulnerable to develop cerebral edema if not managed properly. History of poor or absent control. If the patient is known diabetes, but the one who comes to the emergency room very frequently and has chronic hyperglycemia or chronic poor blood glucose control, he is also somewhat higher risk of developing cerebral edema. And significant lab abnormalities in the beginning, very hyperglycemia or significant electrolyte disbalance, also a risk factor for cerebral edema. More dehydrated patient when was presented in the emergency room if the dehydration is more than 10% and patient has severe hyperosmolarity, that means serum sodium level normally in DKA is in the low normal or to the low side, but if the patient has got hyponatremia at the time of presentation and hyperglycemia more than 700, 500 is very common, 700, and this means the patient has got lost lots of fluid and the dehydration is very severe and the volume contraction is also very severe, and this patient is at risk. And not to talk about acidosis, a pH less than 7 is also a bad sign. So how can we prevent the cerebral edema? There are certain things that we can do that will help us to prevent this serious condition. The goal is to drop the serum osmolarity quickly and therefore prevent the decrease of sodium quickly. It should not be more than 0.5 to 1 milliequivalent per liter per kg per day, per hour. And adjust the sodium. If the sodium is dropping, adjust your saline level in IV fluid. If the patient has got hyperchloremia, and consider using normal saline and ringalactate on ongoing replacement. This also will include if the patient age that I have presented before, that this will be like a 3/4, forget those. If the patient has got problem with saline dropping fast and osmolarity dropping fast, stay with normal saline or ringalactate. And make sure that your sugar is not dropping too fast, ideally less than 100 milligram per dl. And if that is happening, add more sugar, more glucose in IV fluid. If cerebral edema is suspected, should be a clinical diagnosis in the beginning. Assume the patient has cerebral edema, who was doing okay, was talking, and then suddenly there is a changes of the mental status, and that might occur within the first 8 to 12 hours. If you consider this patient fits the profile of cerebral edema, always treat with mannitol, and your dose and everything is there in your DKA handout, and also may have to be intubated before imaging. Always remember the rebound effect of mannitol that might occur after a 1 hour, so that ought to be considered before sending the patient to imaging. So the rebound phenomenon may occur in 30 to 60 minutes time. So observe for that. And that's what, if you are going to get CT, if the patient, make sure the patient is stable for at least about 1.5 hours or 90 minutes. If there is no response of mannitol, consider imaging, because there could be a thrombosis of the brain blood vessels, infarction, that also known to occur in patient with diabetes. So if it is cerebral edema, you would expect some improvement with the mannitol therapy. Now, for your exam purpose, there is pseudo hyponatremia in all patients with DKA, and that's because of hyperglycemia and hyperlipidemia, because that portion of the plasma does not contain sodium. So it is known, it's called pseudo hyponatremia, and there is a formula I have put over there, but I used to remember if the easy way is 1.6 to 1.8 milliequivalent drop of sodium per 100 gram of glucose over 100. So if you can add that fact, you come pretty close to the true sodium level of this patient. Pseudo hyperkalemia is also another problem, and this is secondary to entrance of hydrogen ion in the intracellular place. And so in general, the patient with DKA has significant potassium deficiency. Sometimes elevated serum creatinine is seen, and it might look awful, but it could be due to acetoacetate, which interfere with the measurement of creatinine. But there is an elevation of creatinine because the patient is suffering from severe dehydration. So before I go to this quiz, which will be very helpful for your exam, I just want to mention that when you transfer the patient from PICU to the regular floor, some attendings are conservative and some are pretty liberal, But in general, I think that when the patient's bicarb level has come above 16, preferably 18, patient is completely coherent, normal neurological examination, and eating. Patient is not vomiting, patient is eating food, and that will be a best time to send the patient to the floor, not some clearance. You don't have to wait for the ketone getting out from urine, ketone clearing from the urine, because it takes much longer period of time. Okay, let's come to this quiz and see how much we can get out of this. What percentage of beta cells are destroyed before clinical and sign symptoms of diabetes mellitus? 20%, 40%, 60%, 80%, or 100%? Your answer will be D, because significant destruction of the beta cell has occurred before you develop clinical diabetes, polyuria, polydipsia, ketoacidosis, 80%, and some people will say up to 90%. Number 2 question is, which of the following is a false statement regarding the epidemiology and pathogenesis of type 1 DM? Although we have not discussed about that, but I just put it here because it's such a favorite board question. Even, first statement, even with increase in pediatric obesity and type 2 diabetes, type 1 diabetes remain the most common form of childhood diabetes. The second one is the most common, most patient with type 1 diabetes has positive family history of type 1 diabetes. The next one is not all asymptomatic individual with measurable antibodies against beta cell will develop type 1 diabetes. And the last one is the risk factor of type 1 diabetes linked with the HLA system. Okay, so which one is the false? The false one is B. Most patients with type 1 diabetes do not have positive family history. Maybe about 10 to 15% of the cases you can have family history. Quiz number 3. The first step in the management of DKA is rapid correction of blood glucose, correction of acidosis with bicarb, fluid resuscitation with normal saline, then correction of hypokalemia, and 0.1 unit per kg of fast insulin given as an IV push. Well, I think by now it is clear the first step in the management of DKA is fluid resuscitation with normal saline. So answer is C. Question 4. Initial therapy in DKA management. Insulin therapy after DKA management. After first hour of the fluid therapy, after third hour at the initiation of fluid therapy, and when blood glucose has crossed to 400 milligram and above. Well, the number 1, A, is the answer. Initially we give the fluid, and after fluid is insulin. It's about an hour and a half. Most common death in children with diabetic ketoacidosis is due to cerebral edema. Okay, I put all this thing, but it is cerebral edema. That's what we worry about. In relation to stopping IV insulin and the first dose of subcutaneous insulin, one need to be wait, or one should be given after 30 minutes before stopping it 1 hour before, 30 minutes after, or 1 hour after? Answer is 30 minutes after. Which metabolic derangement is potential complication due to the insulin therapy for diabetic ketoacidosis? Hyperchloremia, hyperkalemia, hypernatremia, hypokalemia, hyponatremia. The answer is D, because once you start the insulin therapy, it pushes the potassium back to the cell, and there is also diuresis of potassium through the urine, and therefore there is a significant risk of hypokalemia if one is not being careful.